Hello, viewers and the followers. Today we will discuss the autonomic pharmacology, that different drugs who are acting on autonomic nervous system. And our today's learning objectives, or by the end of this session, you will be able to understand and discuss the different types of the neuroeffector junctions. Neuroeffector junctions means the junction of the neurotransmitter and the effector cells, how this neurotransmitter produces the effects, and then the synthesis and the action of the neurotransmitters, how these neurotransmitters they are synthesized, they are released, and they acting on the postsynaptic receptors and they produces the effect, and what are the scientific basis for the classification of the drugs, how these drugs they are classified. So these are the today's learning objectives. And when we are talking about the drugs who are acting on the autonomic nervous system, the two sides are very important. One is the neurotransmitter and another is the receptor. So these two sides, that is the neurotransmitter and receptors, they are very much clear to each and every student while talking about the drugs who are acting on the autonomic nervous system. Now this autonomic nervous system is divided into two systems. One is sympathetic system and another is the parasympathetic system. And pharmacologically, this sympathetic system is known as the adrenergic system, depending on the neurotransmitter. As the neurotransmitter of the sympathetic neuron is the epinephrine and norepinephrine, that is the adrenaline and the noradrenaline. So we call the sympathetic system as the adrenergic system, while the parasympathetic system neurotransmitter is the acetylcholine. So we call the parasympathetic system as the cholinergic system. Now this autonomic nervous system, along with the endocrine system, it coordinates the regulation and integration of body functions. The endocrine system sends signals to the target tissues by the levels of the blood-borne hormones, while on the other hand, in contrast, the nervous system exerts its influence by the rapid transmission of the electrical impulses over the nerve fibers through the release of the neurotransmitter. So when we are talking about the sympathetic system, the neurotransmitter is the norepinephrine, which is synthesized inside the neuron, releases at the synaptic cleft, and act on the postsynaptic receptors. While this epinephrine, which is released from the adrenal medulla, it reaches to the systemic circulation and then it reaches to the target cell or effector cells. Though the receptors are same for the epinephrine and norepinephrine, but we can say that the norepinephrine is the neurotransmitter and the epinephrine is the hormone, because it releases from one place, it transported through the blood circulation, and then it reaches to the effector cells or effector tissues. Now the neurotransmitter of the sympathetic system is the norepinephrine, and the raw material which is required for the synthesis of this norepinephrine is the tyrosine. There are certain tyramine containing foods which contain the plenty amount of this tyramine, like cheese is a very important tyramine containing food. It has the food drug interaction that we will discuss in coming sessions. Then the summer sausages, the soya beans, the beans, the peas, and the banana. Banana is a good source of the tyramine and is on the top of the tyramine containing foods. Alcoholic beverages like wine is a very good source of the tyramine. Chicken liver is a good source of the tyramine. Now this tyramine is converted into the tyrosine outside the neuron, and at the neuron there is the tyrosine sodium pump, co-transport pump, which transport this tyramine, converted into the tyrosine and then transported inside the neuron. And this tyrosine, when acted by this enzyme, tyrosine hydroxylase enzyme, is converted into the dopamine, and this dopamine is finally converted into the norepinephrine, which is packed inside the vesicle. Whatever the neurotransmitter is, it should be packed inside the vesicle, because there is the monoamine oxidase enzyme system which is present inside the neuron, and it causes the degradation of the neurotransmitter if it is not packed inside the vesicle, and there could be possible deficiency of the neurotransmitter. So the packing of this neurotransmitter in the vesicle is must. When the action potential reaches to the neuron, there will be the opening of the calcium channels, and there will be the entry of calcium inside the neuron, and this calcium will attract this vesicular membrane towards the neuronal membrane. There will be the fusion of this vesicular membrane with the neuronal membrane, and there will be the exocytosis and release of the neurotransmitter at the synaptic cleft, and this neurotransmitter then come and bind with these post-synaptic receptors and some of the neurotransmitter at the pre-synaptic receptor. Now this pre-synaptic receptor is the alpha-2 receptor, which is the auto-regulatory receptor. It auto-regulates the release of the neurotransmitter when there is plenty availability of the neurotransmitter, and this alpha-2 receptor, they are being activated. They creates the inhibitory signals to the neuron that now I have the plenty availability of the neurotransmitter, so please stop releasing the neurotransmitter. So we call those alpha-2 presynaptic receptor as the auto-regulatory receptors. We have this norepinephrine reuptake pump at the neuron. When neurotransmitter releases at the synaptic cleft, it come and bind with the receptors. This neurotransmitter then again pumped inside the neuron, and we call it as the reuptake of the neurotransmitter. And when this neurotransmitter is reuptake back into the neuron, it is this is packed inside the vesicles, they repacked inside the vesicles, which prevent the interaction of this neurotransmitter with this monoamine oxidase enzyme to prevent the further destruction, intraneuronal destruction of the neurotransmitter. Now the drugs that produces the primary therapeutic effects by increasing the functions of this sympathetic system, they are the agonistic drugs. They enhance, they mimic the sympathetic activity, so we call those drugs as the sympathomimic drugs. And there is another group of the drugs which decreases the activity of the sympathetic system. They are the antagonistic drugs, so we call them as the sympatholytic drugs. Now the sympathomimic drugs, they are classified into two groups, that is the directly acting drugs and indirectly acting drugs. Those drugs who are acting directly on the receptors and they activate the sympathetic receptors, they mimic the sympathetic activity, we call those drugs as the directly acting sympathomimic drugs. Those drugs who are mimicking the sympathetic system but not directly acting on the receptors, they are indirectly acting sympathomimic drugs. Like this, there are certain type of drugs who inhibit this norepinephrine reuptake pump, and when this pump is being inhibited, so this neurotransmitter remains for the longer duration at the synaptic cleft. And when the neurotransmitter remains for the longer duration in the synaptic cleft, so the neurotransmitter receptor activity will be prolonged and it produces the enhanced effect. So we call them as the indirectly acting sympathomimetic drugs. And this is the scientific basis of dividing or classifying these drugs into two groups, that is the directly acting and indirectly acting drugs. Where this neurotransmitter come and bind? What are the types of the postsynaptic and presynaptic receptors? So these sympathetic receptors are divided into two groups, that is the alpha receptors, and the alpha receptors, they are subdivided into two, that is the alpha 1 and alpha 2. Alpha 1 receptor is linked with the GQ. It means this alpha 2 is linked with GI. It means both these receptors, they are G protein coupled receptors. So they are the serpentine type of receptors. They have the 7 transmembrane helicals. They are attached with the G protein, and this alpha 1 receptor, they are linked with the GQ, and the alpha 2 is by the GI. And as I have just discussed about the alpha 2 receptor, that it is present presynaptically, and they are the autoregulatory receptors, and they create the inhibitory signals to control the release of the neurotransmitter in the synaptic cleft. What about this alpha 1 receptors? That this alpha 1 receptor, they are the serpentine type of receptor. They are linked with the GQ, and when the neurotransmitter or the drug, agonistic drug, come and bind with this receptor, they activate this GQ, which activate the phospholipase C enzyme, and this enzyme increases the availability of the IP3 inositol triphosphate and diacylglycerol, which finally increases the mobility of the calcium inside the cell. So all the effects which are being produced by the alpha 1 receptors, they are by increasing the mobility of the calcium inside the cell. Now here question arises, what is another important step? Another important step to discuss is that what is the important location of the alpha 1 receptors? That alpha 1 receptors, they are present on the blood vessels, smooth muscles of the blood vessels. And when this alpha 1 receptor, they are being activated, the phospholipase C is being activated, the mobility of the calcium is being activated, and the resultant effect is the vasoconstriction. It causes the vasoconstriction because the calcium causes the contraction of the smooth muscles of the blood vessels, and because of this vasoconstriction, it causes the hypertension, or it increases the blood pressure. That is the resultant pharmacological effect by activation of the alpha 1 receptors. Now, what is the another family of the sympathetic system receptor or sympathetic receptor? That is the beta receptors, and they are subdivided into beta 1, 2 and 3, 4 and 5. And all these beta receptors, they are again G coupled linked receptor, and they are linked with the GS, that is stimulatory. This is the beta receptor, serpentine type of receptor linked with the GS. When any this neurotransmitter like a norepinephrine of any drug come and bind with receptor, it will activate the GS, and GS will activate the adenylate cyclase enzyme, and this adenylate cyclase enzyme increases the availability of the cyclic AMP, and now it's the duty of cyclic AMP is to produce the effects. Another important step where these receptors, they are present. What is the location of this receptor? Now the topmost location of the receptor of beta 1 is the heart. Beta 1 receptors, they are present at the SA node, that is the pacemaker. And when this receptor, they are activated, G protein coupled receptor linked with the GS, when the receptor is being activated, there will be increased availability of the cyclic AMP, and this cyclic AMP opens the calcium channels at the pacemaker SA node and increase entry of the calcium and the SA node. It increases the heart rate, and this increases heart rate definitely contributes to the blood pressure. And the antagonistic drugs, they definitely produces the opposite effects. They block the receptors and they produces the opposite effects. Another important location of the beta receptors, that is the blood vessels. Blood vessels has the dual population of the receptors. Alpha 1 receptors are present and the beta 2 receptors, they are present. So these when these alpha 1 receptors, they are equal in number with the beta 2 receptors, there is the normal structure of this blood vessel. There are certain type of the blood vessels who causes the vasoconstriction because they have alpha 1 receptor more than beta 2 receptors. So they causes the vasoconstriction. And when there is the release of the neurotransmitter or the drugs who are acting on alpha 1 receptors and they have the increased population of the alpha 1 receptors, they causes the vasoconstriction. And there are other type of the blood vessels which have more beta 2 receptors than the alpha 1. So definitely it causes the relaxation of the smooth muscles of the blood vessels and it causes the vasodilation. So the same neurotransmitter norepinephrine which releases and act on some type of blood vessels, it causes no effect because of the equal population of alpha 1 and beta 2 receptors. The same neurotransmitter will act on another type of the blood vessels, it causes the vasoconstriction because the increased population of alpha 1 receptor. The same neurotransmitter norepinephrine releases and it causes the vasodilation because when it acts on the blood vessels which contain the increased population of beta 2 receptors which causes the vasodilation. Action or the location of beta 2 receptor on the smooth muscle is a very wide statement. Wherever the smooth muscle is present, it causes the relaxation. So this is where one most important location is the blood vessels. Another important location is the smooth muscles of the lungs and the bronchial tree. We have got the same beta 2 receptors and again they causes the relaxation or the bronchodilation. So this beta 2 receptor agonistic, they causes the bronchodilation. This is the pharmacological effect, but the clinical use, and they are very commonly used to treat the patient of bronchial asthma. Because in the bronchial asthma, there is the excessive bronchoconstriction, and because of the bronchoconstriction, the patient feels the dyspnea and difficulty in breathing. So these beta 2 agonistic drugs, when it act on the beta 2 receptors, they causes the bronchorelaxation and they causes the relief to the asthmatic patient. Another side where the smooth muscle is present is the uterine smooth muscle, that is the uterus. Beta 2 receptors, when activated, it causes the relaxation of the uterine smooth muscles. The very valid clinical use of this beta 2 agonistic drugs is the premature labor. Premature uterine contraction produces the premature labor, and we can stop this premature contraction by the beta 2 agonistic drugs, and we can prevent the premature labor. And the most commonly used beta 2 drugs, they are used for the premature labor, and this effect we call as the tocolytic effect of the beta 2 agonistic drugs, very commonly used for this purpose, for the delaying the labor, premature labor. So this is the another pharmacological effect and the clinical use of this beta 2 agonistic drugs. Now this is about the cholinergic system, and the neurotransmitter is the acetylcholine. This is the form. This is again the neuron. This is the synaptic cleft, and these are the post-synaptic receptors, acetylcholine receptors. This is the synthesis of the acetylcholine. Again, it is packed inside the vesicle. Again, there will be the entry of calcium, attraction of this vesicular membrane with the neuronal membrane, exocytosis, release of this neurotransmitter, act on the postsynaptic receptors. But here, there is a difference between the norepinephrine and acetylcholine. There is no reuptake system which get this neurotransmitter back into the neuron. Here we have this acetylcholine esterase enzyme system which break this acetylcholine into two parts, that is the choline and the acetate. Acetate is being excreted out and this choline is recycled back into the neuron. And inside the neuron we have the enzyme system, that is the acetyl-CoA enzyme. And this acetyl-CoA enzyme transfer this acetyl group to this choline, and again there is the reformation of this neurotransmitter, that is the acetylcholine, which is again ready for the next release. Again, here we have two types of the cholinomimic drugs, the antagonistic, the agonistic type of drugs. Again, these drugs, they are divided into two groups, that is the directly acting drugs and the indirectly acting drugs. Directly acting drugs are those drugs who directly come and bind with the receptor and produces and mimic the cholinergic effects. Now, another group is the indirectly acting drugs who act on this enzyme, that is the acetylcholine esterase enzyme, which inhabits the acetylcholine esterase enzyme. When this enzyme is being inhibited, the breakdown of this acetylcholine into the choline and acetate is being inhibited, and this acetylcholine remains for the longer duration with the receptor. More neurotransmitter receptor interaction, and it produces more effects. And these indirectly acting drugs, or the acetylcholine esterase enzyme inhibitors, they are again divided into two. That is, it might be the reversible inhibitors and it might be the irreversible inhibitor. Reversible inhibitor, they might inhibit and they might not be inhibited, and the irreversible, that they are permanently deactivate the acetylcholine esterase enzyme. So again, the classification of these cholinomimic drugs, they are on the basis of the neurotransmitter release and its degradation. Now, the another step is that what are types of the cholinergic receptors? Again, the two families, that is the muscarinic receptors and the nicotinic receptors. Muscarinic receptors, they are again subdivided into three. There is the M1, M2 and M3. And all these three receptor families, M1, 2 and 3, they are again G protein coupled receptors. That is serpentine type of receptor. That's M1, they link with GQ. Again, it's the mobilization of the calcium. M2, that is the GI, inhibit the adenylyl cyclase enzyme and decreases the availability of the cyclic AMP. And M3, that is acting through GQ, again, that is the mobilization of the calcium. And the important point, another important point is what is the location. M1 receptors, they are present on the nerve endings. M2, heart, and they decreases the cyclic AMP. So they decreases they prevent the opening of the calcium channels at the pacemaker SA node, so they decreases the heart rate. And M3, they are present on glands, and they are working through GQ. They mobilizes the calcium. Calcium causes the exocytosis, so they increases the release of the glandular secretions. And the important structure, which is very important as far as the cholinergic system is concerned and the muscarinic receptors they are concerned is the eye, that is the ophthalmic structure, and in this ophthalmological structure, eye structure, two important location of these receptors and three receptors, that is the insphincter and the ciliary muscles. They are present on the insphincter muscles and the ciliary muscles. So when the M3 calcium is mobilized, it causes the contraction of the sphincter muscles and it causes the meiosis, that is the contraction of the pupil, and ciliary muscles contraction, it causes the accommodation for the near end. So another important is the heart that we have discussed, that this M2 receptors they are present at the SA node and the AV node, and they decreases the heart rate. And in the lungs again we have the M3 type of receptors in the lungs. So not in the lungs but also in the secretory glands. So at one place they causes the bronchoconstriction because of mobilization of the calcium, and they increases the bronchial secretions, that is the M3 receptors, and that's why we use the anticholinergic drugs which are M3 specific blockers which block the M3 receptors, and they are very valid place for the treatment of the bronchial asthma. Then another is the nicotinic receptors. They are present in the autonomic ganglia, autonomic and this neuromuscular junction. We have this nicotinic cholinergic receptors, and these are the ion channel coupled receptors. There is normally a slow release of the acetylcholine neurotransmitter. They are acting on a neuromuscular junction. They activate the nicotinic receptors. They create the slow action potentials, and these slow action potentials, they are very much important and needed for the normal muscle tone of the body. So these are hold the general outline for the autonomic nervous system, and we have the two type of the systems, that is the sympathetic or the adrenergic system and the cholinergic system or the parasympathetic system. And important points that everybody should know, that is what is the neurotransmitter, how it is synthesized, how it is released, how it is reuptake back, or it is being degraded by the enzyme, and what are the postsynaptic and presynaptic receptor, and what are the transduction mechanism linked with these receptors, and finally and more important, that is what is the location of these receptors and what are the resulting effect of these receptor neurotransmitter interaction. Thank you very much.